Do you mind if I will move those things just a little bit?
Move what?
This projector, just a little bit?
I don't know if you can.
Because I'm high enough to just...
To see if you can. I don't know if you can. I don't know if it'll stay, is the problem.
I think it will stay. Sorry about that.
Why is that not working? Oh, it would help if I connected the laptop. That usually helps. The poor laptop. Multiple percent. Which one are we talking to now? Okay, so we left off talking about cardiograms last class, didn't we?
Yeah.
What's a cardiogram? Yeah, what's a cardiogram? EKG, ECG. It measures what? Electrical activity, okay? So you're picking up what? What's it? What are you looking at when you look at a... Yeah, what are you picking up? What are those cells? Or another name for them? Autorhythmic cells. So you're picking up the messages being sent by the autorhythmic cells that cause changes in electrical events. You also are measuring the relaxation, the repolarization based on those events. Systole, diastole, contraction, relaxation. Those terms are synonymous, right? Synonyms. So, know the parts of a cardiogram. The P wave, atrial depolarization. QRS is ventricles depolarization and atrial repolarization. And then T wave is ventral repolarization. Okay? So know those parts. Now, when you look at this diagram, it's nice because it shows you exactly what's going on and where that message is being sent. You don't have to memorize it. You just have to understand that this is a visual way of seeing the chain reaction of events that is going on in the conduction system.
In our textbook, there's a few examples of how you can breathe.
Yep, and there, you can look at... No,
Because
we're going to talk more about that in lab.
Okay.
So when you, in lab, you'll talk about what this means. So the distance between the peaks, these intervals, the PR, the ST, the QRST, intervals have a lot to do with the integrity of the heart muscle itself. When things are too far apart, we can tell that there's problems with the heart muscle itself. So when a cardiologist sits down and reads a cardiogram, they do it with a little ruler. And when you look at this, you can actually see the tracings on, does this show it? Yeah. See the paper? It's measured graph paper. So there should be a certain distance between peaks. There should be a certain height of peaks that fall within a normal range. And that can tell the doctor a lot about what's going on with your heart. It's only picking up conduction system, but the distance between them can also give you information as well about the integrity of the heart muscle. So up there we see what we call normal sinus rhythm, PQRST, PQRST, and then we see abnormals. So these are some abnormal tracings, and these are some of the reasons why we see them. So when, for example, we have a second degree heart block here. There's a problem with not conducting through the atrioventricular node. So the AV node, which was part of the conduction system isn't doing what it's supposed to do. And we see an interruption in message on the tracing. So in lab, you'll talk more about those measurements, okay? But this tracing is extremely important for the cardiologist. It's a baseline. The next thing the textbook talks about is the heart sounds. So the sounds I hear when I put the stethoscope on your chest. Heartbeat, lub dub. That's how we describe it, right? Those are the sounds you hear. What are the sounds? Is it blood moving through the heart? No, you can't hear that. What is it? Watch this. You ready? Watch this. Don't listen to the handle open. I love this demonstration. Okay, pretend you didn't hear that. Ready? Watch this. Did you hear anything? Watch this. Did you hear anything? So when the valves close shut, those are your heart sounds. Well, why is there only 2 heart sounds?
There's one that wells that with the AV.
So they're going to happen at the same time. So pretend I have 4 doors in my heart, right? What are the 4 doors? What are the 4 valves? There's 2 atrioventriculars, right? Right and left atrioventricular, and there's 2 semi-lunar valves. So when they close at the same time. So you're going to get 2 heart sounds. You're going to hear lub, dub. And this diagram shows us those valves when they close and when you would hear them. Pretty darn close. It's hard for the human ear to distinguish the difference.
Yeah, but there is some, right?
It's very, you can't distinguish it because your hearing isn't that sensitive.
So the valves close at the same time. All 4 valves are closing at the same time?
No. 2 valves are closing, 2 valves are closing. And when is it going to happen? Now, here's my favorite diagram in the whole book. You ready? Because this diagram ties all the information together. Well, this one's going to help you understand all the events that are going on. This is a diagram entitled, and this is on page 680 in your textbook, Summary of Events During a Cardiac Cycle. What the heck is a cardiac cycle? P, Q, R, S, T. Ventricles and atria contract and relax. That's 1 full cardiac cycle. So 1 heartbeat, basically, where you're going to hear the 2 heart sounds, lub, dub. At the top, we see what we've already learned. So you see P, Q, R, S, and T. That's what we see in an electrocardiogram. We hear the heart sounds when what happens? QRS, what's happening? The ventricles are contracting. So if you follow this down, you can see the pressure in millimeters per mercury in the aorta. We can see it in other areas of the heart. We can see where the blood is in the heart by looking at this portion of the diagram. So we can look at the blood volume, which is the highest when we're right there, and then lowest when the ventricles do what? Contract. You can see here in the diagram which valves are open and which valves are closed during this. So do you see how it's all tied together? So atrioventricular valves are open during what? P. And what's happening during P? See, they're all tied together, so follow the stripe up.
It's
Atrial contraction, right? Atrial depolarization. So the atrioventricular valves are being forced open. Did I hear that?
Yeah.
Remember, I didn't hear the door open. First heart sound comes when QRS happens. When what closes? Atrioventricular valve slams shut. Because why?
Because the pressure.
Exactly. The pressure increases, gives it a back push, because who's starting to contract? Ventricles are starting to contract. What happens to the volume in the ventricles when the ventricles contract? I know. It's all right. I got it. What happens when the ventricles contract?
Less blood.
Blood is being pushed out. So what happens to the volume in the ventricles during see it? So this is awesome because it brings it all together in one picture for you. So who opens up when the ventricles contract? The aortic and pulmonary valve, the semilunar valves. When that pressure starts to build up in the ventricles, it's going to push open the semilunar valves and it's going to slam shut the what? Atrioventricular valves. So now we see the atrioventricular valves closed, bam, lub, first sound, and the semilunar valves open. When is the semilunar valve going to close?
They close by the pressure of the blood that rushing out of the heart.
So it rushes out, but not rushing out of the heart, but when the ventricles start to relax,
Relax and then pushing the blood.
not pushing out, they're now kind of pushing, you're getting back pressure from the blood that's in the heart. Exactly. So they stop pushing it out, the back pressure is going to do what? Slam the doors shut. Make sense?
When it's leaving the heart, right?
No. When the ventricles contract, it's going to push the doors open. When the ventricles relax, blood's already left the heart. The ventricles relax, the back pressure is going to close the doors. Yes? That's a cardiac cycle.
That's why
Each-
its pressure is low.
Exactly.
Because it's relaxing.
You see? And that's the beauty of this. It's all in one place. Everything's all lined up for you. You can see what's happening in the cardiogram. You can see what's happening with the pressure within the different chambers. And down here, you need to know these. Each of these phases of a cardiac cycle has a name. Okay? So during ventricular filling, stage 1, we see ventricular filling due to atrial contraction. And that's all described in words in your textbook. A lot of words. So I'm making it simple for you, yes? Then you have ventricular systole, atrial diastole. Stage 2A, we have isometric contraction phase and ventricular ejection phase. And then last but not least, what do you have? Everybody's relaxing, waiting for the next what?
Contraction.
Next contraction of the atria. So that's when, just by the fact that pressure alone is pushing things through, we start the ventricular filling stage again.
So the systolic pressure would be the atrial contraction.
No. Systolic blood pressure, is actually measuring the pressure created by the contraction of the ventricles.
Yeah, that's
Because
ventricle contraction.
you said atrial.
No, ventricle.
Okay, ventricle.
Sorry,
So the ventricles are creating, and think about where the pressure is being picked up. You can't really feel in the system atrial contraction. When ventricles contract, what are they going to do? They're going to push out a big volume, yes? And that's when you feel the pressure outside in the system. So when you take a blood pressure in your arm, the systolic pressure, which is the high number, is representative of the highest pressure in the system. And that's due to what? Ventricular contraction. When the ventricles start to relax, that's your what? Diastolic pressure. And that represents the lower pressure in the system. Make sense? Because again, you're thinking outside the heart when you measure blood pressure in your arm.
But I thought that this is the diastolic pressure is actually atrial systolic. This is how it says here. Pressure.
Well, that's also when you look at the cardiogram, remember QRS, ventricular systole. What's happening during ventricular systole?
It's a contraction.
What else is happening?
Atrial.
Relax.
Arterization.
So that's atrial diastole. You're not measuring that in the system. You can't measure that in the system.
No, I mean atrial systole.
That's contraction. I'm not measuring that in the system. Make sense?
Yeah, just what confused me in this diagram, it says pressure. You see the atrial systole? There's a
Right. That's also showing you the pressure, that pressure blip during atrial systole. So this is the atria. This is the ventricle. Yes? So they're showing you both.
So this is the when ventricle relaxed, it's the system. I'm sorry, contract. This is the systolic pressure.
Correct.
And when it's relaxed, this is systolic pressure.
Correct.
Okay.
So ventricular systole, high point in blood pressure. Ventricular diastole, low point in blood pressure. Because you can't measure atrial and systole and diastole in the system.
Okay. Because it's too low.
Correct. And it's disrupted by the pressure wave from the ventricles. Okay? So understand those steps and understand my favorite diagram of all. You're going to have to do some math. Oh, math! You're going to need your calculator for the next exam.
Oh dear God.
Oh, dear God, yes. And your first math problem is going to be cardiac output. Page 680. It's simple. Let's make it simple. It is simple. Cardiac output. How much blood the heart puts out in any given what? Any given minute. So first of all, what I have to know is how many times is the heart pump per minute? What's that? Well, a pulse, or in the problem, heart rate. So how many times the heart beats per minute? So the average, what do they use here? 75 beats per minute. So that's an average. Right. So let's use, because the numbers are right there in the book, let's use the numbers in the book. Because God forbid I bring my calculator with me. So 75 beats per minute. My patient, I've measured their pulse, and that's how you measure the heart rate, is taking their pulse, right? Gives off 75 beats per minute. Now, the other question I need to ask myself is how much blood is that patient squirting out every time the heartbeat happens? What's that volume called? Stroke volume. Okay, so that is, and that you can't take. That's something that is calculated. It's something that you have to actually go in and internally measure. But it can be calculated on some of your different things based on patient's age, based on patient's weight. So again, in this problem, they used an average of 70 mils. So every time this patient's heart beats, every time the ventricle ejects blood, which ventricle? To the system? Left. Every time the left ventricle contracts and ejects a volume into the system, this patient is ejecting 70 milliliters of blood. So in order to find out how much blood, cardiac output, this patient is circulating through their system every, what, minute, we have to multiply the heart rate, beats per minute, times the volume, stroke volume. Correct. Every beat. So for every beat, 70 mils times 75 beats. There you go. So that patient, this one in the problem, is pushing through their body 5.25 liters of blood per minute.
How are we knowing when to move the decimal point? That's the biggest thing.
That's math. Why is it? Use a calculator, girl.
That's converting from
milliliters to liters.
Oh, the metric system.
Yep.
That's
How many liters? 100?
1,000.
1,000?
Yes? So that just basically converted it.
so 5.25 liters is.
Probably the patient's whole
I
what?
was gonna say a large majority of what
Their
they-
entire volume. So you,
6 to 7 liters.
5 to 6.
5 to 6.
So you, the average normal person, moves their entire blood volume through the heart every minute.
In 1 minute.
Correct. Amazing, isn't it? So a normal adult, again, these are average numbers, and in order for you to calculate your cardiac output, what would I have to give you?
Give us stroke value.
Exactly. I'd have to give you that information. The next test you have, what you're going to see is a patient chart. And in that patient's chart, you are going to see information like heart rate, like stroke volume, and some other things we'll see for our other math problems that we're going to have to do on our next exam. So it's going to be a patient chart, and you have to go get the information from the patient's chart to do the math. Yes?
Do you have to know end systolic volume and end of systolic volume?
No, I'm not going to make you do those calculations. No.
It's a little confusing.
That, again, you'll discuss in lab. Okay? So,
Can you
number one, math problem. Put a big star beside it. Cardiac output. You're going to have to calculate it on your next exam.
please explain the difference between end of diastolic volume and end of systolic volume?
It would be the end, and that's what you see here. At the end of diastole, the volume of who? No, of who?
End of diastole.
So the end of relaxation in the ventricle, it's the fullest, isn't it? So end diastolic volume. Once the ventricles relax, before they contract, you see how high it is? And then during systolic volume, you see the big drop and change, and then the end systolic volume. After the end of the contraction, the volume. So we're talking about ventricle.
Okay. It's before and after contraction.
Yeah, so after relaxation fully, and then after contraction fully. All right, so stroke volume, how much blood the heart pushes out, depends on how hardy the heart is. Problems can be with patient's heart muscle and the integrity of patient's heart muscle. And think of this. I think of a rubber band. You know when you get a new rubber band out of the package? It's nice and tight and taut, and you pull it and you let it go, and it bounces right back to the way it should. That's what they're talking about under contractility of the heart muscle. So normal heart muscle has a nice contractility. It's able to stretch, fill the volume, push out the volume efficiently. If you start having problems with contractility, the muscle itself starts to degrade and generate. Think of the elastic. What happens to it when it gets older? It might stretch. It's got less, get back to normal in its stretch. So when we, or less stretching and emptying power, if that muscle starts to get, and I always say the word flabby because that's what it makes me think of. You can't come back to that nice taut place and push out the volume that you should. So contractility of the heart muscle itself, for whatever reason, if the patient's heart muscle starts to degrade and we decrease contractility, we're going to affect stroke volume because we're not going to be able to push out as much volume during a stroke volume. Pressure in the system, preload and afterload. That's what they're talking about when they talk about pressure in the system. If I'm pushing too hard on something, it's going to have a hard time pushing against me. So pressure in the system can affect stroke volume by affecting the ability of the heart to push that volume out. We might go too much, we might go too little, depending on the pressure in the system. So the pressure in the system can affect stroke volume as well. Who helps to regulate heart rate? And that's where this diagram is going to come into play. So who's in charge of heart rate? Ultimately.
The autonomic.
Central nervous system, right? Okay, one of the guys that's going to help me out is the cranial nerve 10. Who's he?
Vegas.
The vagus nerve. And heart rate is based on a couple of things that the central nervous system is constantly monitoring. So, if I look at this diagram, I'm going to see its effects, different physiological effects on cardiac output. Remember, I'm going to affect one of the numbers in my formula. So, exercise. Increased sympathetic activity, increased muscle activity. What's that going to do to cardiac output? This diagram, everybody's going to increase. Just telling you. But why?
Contractility will.
I need more oxygen. Nervous system picks that up. How am I going to get more oxygen to my tissues at a faster rate? Push more blood volume through the heart at a faster rate. So what's going to happen to heart rate? It's going to go up. What happens to cardiac output then? It's going to go up. Okay, so we're going to increase venous return, respiratory pump, muscular pumps. Remember when you discussed the muscular system? What was one of the things that brought blood back to the heart? Oh no, you haven't talked about it. We're talking about this semester. When we talk about venous return, bringing blood back to the heart, one of the things that's going to help do that, think about your lower extremities. This is the best example.
Muscles?
You're working against gravity, right?
Yeah.
So,
Muscles will push
exactly. Muscles will push against the tubes and push blood back up to the heart because the pressure goes way, way low in the venous system. So we have the respiratory pump. So what happens to you when you have to run down the hall? Besides your heart rate increasing, what else increases? You start to breathe faster. Respiratory pump, the muscles in your respiratory system or in the thoracic cavity are also going to push against those tubes. So the faster I breathe, the faster that push will be on those tubes for venous return. So muscles from the legs, you moving, and muscles from you breathing at a faster rate are going to push on those major blood vessels and increase venous return. That is going to then increase end diastolic volume. Because everybody's pushing from behind, right? They're all going to fill up the atria, and then that's going to also increase the volume that goes into the ventricles as well, because everybody's pushing from behind. You'll increase end diastolic volume, preload.
So is it the same as venous return and diastolic volume?
Well, it's not the same, but venous return increasing is going to increase end diastolic volume because there's going to be more blood pushing from behind. Mm-hmm. Am I making sense? Okay. That's going to increase stroke volume, more blood in the heart. That's going to increase cardiac output. Contractility. I have to stretch more if I have more in me, right? That's going to increase end systolic volume because everybody's pushing from behind. I'm going to end up pushing more what out?
Blood.
More blood. Increased stroke volume, increased cardiac output. Not only exercise, physical exercise can do this, but chemicals can do this too. Epinephrine, thyroxine, calcium can all affect cardiac output. So if my patient has problems with calcium, for example, too much calcium in their system, they're going to have an increase in cardiac output. They also might have an increase in what? Heart rate. They might have an increase in pressure in the system. Exercise. We think, okay, yeah, I get that. But fright and anxiety can do the same thing. You ever get really scared by something? And if I slammed that door really hard and scared you, you take a deep breath in and your heart starts to beat. So those things can also increase cardiac output by increasing your heart rate. Anytime I mess with a number in the formula, I'm going to mess with cardiac output. So if I decrease heart rate, I'm going to decrease output. If I increase either one, I'm going to increase cardiac output. Yes? Good. Chemistry again. But this is basically what kind of hormone? water soluble. Thank you, dear. And we're setting off what kind of second messenger system? This happens to be the cyclic AMP second messenger system and adenylate cyclase. So this basically shows how hormones are going to affect the cells. Don't worry about that. That's good. Regulation of heart rate, we're good. Autonomic nervous system is going to help regulate how fast or slow heart beats. Sympathetic is going to do what? Increase heart rate. I'm just going over the, on page 684, I just wanted to quick mention the autonomic nervous system regulation of the heart.
I should know this by now, but what's an easy way to remember sympathetic and parasympathetic? Are there any tricks?
Thank you so much for asking.
Because
Well, I always remember, I have sympathy for you, I'm going to feel bad for you, I'm going to run over to you and help you out quickly. And then parasympathetic, you're all set, you're done, we can relax.
Sympathetic is stress, both ends.
Yeah, I also
Stress.
remember that this is fight and right?
Yeah, fight or flight.
Or flight,
Yeah.
yes. Fight or flight. And
So I have sympathy for, I'm going to help you, I'm going to run to you quickly.
So sympathetic is
Speed up. Parasympathetic,
come down.
slow down. And again, I use this example with my students in AMP1. Have you ever tasted the hermits they make in the culinary arts guys make in the cafeteria? Or they make them in their classes, but then they sell them in the bookstore? Oh, they're so good.
What's a hermit?
What's a hermit? Oh, it's a wonderful cookie. It's got nutmeg and cinnamon and raisins, and it's tasty, tasty. So when I hear there's hermits for sale in the bookstore, I'm going to run to the bookstore as fast as I possibly can. Who's going to help me get there? Sympathetic. Speed up. Muscle speed up. Respiratory rate speeds up. What else? Heart rate speeds up, right? I'm going to run to the store, go get my cookies. Once I have secured the cookies, I am then going to find a nice quiet spot to enjoy them. What's going to happen to all those guys? Parasympathetic's going to kick in and we'll relax. Okay? Yeah.
In those charts that you will give us, for example, for measuring cardiac output, how you would put stroke volume?
I'll say stroke volume.
Oh, that would
Yep.
say stroke volume.
So I'm going to put a chart that's, and you'll see why I need more, because in the respiratory system we're going to need more numbers. There's going to be more math, yes there is. So you need more numbers to calculate other things, and you'll see that in the next chapter. No, we don't need that for this particular math grouping, but you need the patient's weight. You'll need stroke volume and all of that, and we'll see that in the next chapter. Okay, couple of definitions you should know. Tachycardia, bradycardia, what's that?
tachycardia is high, brady's low.
Increased tachycardia, increased heart rate, bradycardia would be low heart. What's the problem with either of those?
Sometimes it's good to have a free.
You're either putting too much blood volume out or too little blood.
Yeah, and watch this. Am I getting a nice big fill me up and push me out? Yes, that's tachycardia. So it's going to affect stroke volume and it's going to affect cardiac output because we're not getting a nice big fill up and push out. If it's going too slow, same thing. We're not getting enough out there fast enough.
But it's not for people who are like sportsmen that using.
Right, but abnormal.
Applied for it actually, because when you're working out.
But what happens to those sports people? They increase their stroke volume because their muscle efficiency is much better. So it ends up being a benefit to them.
Yeah.
We're talking about in an abnormal situation.
Somebody who's in pain, like they'll do tachycardia more often because they can't deal with the pain, so it's more shock to their system.
or just somebody whose heartbeat is so rapid, and it could be for chemical reasons as well. And you're just not getting an efficient distribution of blood through the system. So abnormal, not I'm exercising, my heart goes up. I'm sitting down reading the newspaper and I have a heart rate of over 100. That's not normal, okay? So, know those definitions. A couple of homeostatic imbalances of cardiac output, also know those definitions. Atherosclerosis, we're going to talk about that a little bit in the next chapter. But again, if those blood vessels aren't pliable the way they should be, they're not going to be able to stretch and push out volumes properly. High blood pressure. If I overwork a pump, I am going to wear it out faster. And remember, your heart is a pump. So if there's too much pressure in your system, cardiovascular system, you're going to wear out your pump faster. So high blood pressure can have an effect on the heart. Atherosclerosis. It's all under homeostatic imbalances of cardiac output, page 685.
What do we have to know about the second distribution that you showed us?
That's just, you don't have to know anything about that. Just know that that's the mechanism in which the hormones help to regulate cellular function. Multiple myocardial infarction. This is basically parts of the heart muscle are dying because they're not getting blood supply. And that's going to, again, affect the fill up and the push out, affect cardiac output on the long run. Okay, and then dilated cardiomyopathy, DCM, drug toxicity, alcohol, cocaine, wreak havoc on the autorhythmic cells. Okay? Right, because it can be so varied. It can have, if you ask me, give me one, there's tons of different things that can happen.
So in this condition, the ventricles stretch and they not able to contract properly?
Correct. So it's like that stretch out elastic now. They're not able to come back and push out the volume that they should. Well, they're still there. It's like me, again. Right, or they've just been, the muscle itself has been stretched out, like that old elastic. Yeah. Okay, and that, my friends, is the end of chapter 18.
So we don't need to know anything about the developing heart.
Nope. You want to do a couple questions?
Yeah.
All right, apex of the heart points where?
That's right, it's not high, it's low. Because the apex, you think it's high.
Toward the left here with C.
It would be C, towards the left. Yes, so it's at the bottom, left. What's the double-walled sac covering the heart? Yep, pericardium. Of the following layers of the heart wall, which consumes the most energy? Yeah, the muscle, the myocardium, right? And one more. Which of the following structures is an exception to the general principle surrounding blood vessel oxygenation levels?
It's a
Pulmonary artery and? So it would be D.
Oh, yes,
A and C. Okay? So we good? No, we're already behind. We are behind. Okay, so now in chapter 19, we've gone past the pump and we're going into the tubes. So what are the tubes?
blood vessels,
Arteries and veins. So now, because of the fact that arteries, which carry blood what? Away from the heart, are under so much more pressure. we're going to see that the makeup of the walls of an artery versus the makeup of the walls of a vein are going to be different because of that pressure difference. So you need to understand the difference between an artery and a vein's makeup. Now, the lumen or space that we're pushing the volume in an artery tends to be smaller in diameter than the lumen or space in a vein. Does blood move faster through a smaller lumen or faster through a larger lumen?
Larger.
You think it moves faster through the larger lumen?
I think yes, because
You think so?
no, because it's more space to faster. I don't know about faster,
Not as
but
much
more
pressure.
blood will.
Let me give you an example.
There's not as much pressure.
At my house, I'm cheap. I have a hose that comes from my house, but I'm too cheap to buy one of those fancy little nozzles. And I have this rhododendron bush that's a little bit further away than all the rest of my other plants. Same pressure running through my hose, right? I turn the hose on, it goes, but I want to water my rhododendron bush. What do? I put my thumb over the end. I make the lumen what? Smaller. You get it now?
No, I thought that you're asking how many blood.
No, I said which moves faster.
No, I'm sorry. That I thought that how many blood. The blood volume will go not faster, but more blood.
Well, the volume's there. Everybody's still pushing, remember? Okay? So, the blood will move faster through a smaller lumen. Remember, arteries are going to bring blood to where they need to go. So let's get there. What's happening in the veins? Everything's coming back to drop things off, get another push. Where am I bringing things to? Here. This is the business end of the circulatory system. This is where exchange happens. What is this? Capillary beds. And we're going to see that the lumen of the capillary bed is very small because the lining of the capillary beds is only what? One cell layer thick, the endothelial cells. So when we look at the makeup of these two different blood vessels, we're going to see in the artery a smaller lumen, so blood can move faster. In the vein, larger lumen. The pressure is also lower in the veins than it is in the arteries, and we'll see that in this chapter. Because the pressure is higher in the arteries than it is in the veins, the walls are different also. They have to be able to withstand the higher pressure inside the artery. So what we're going to see in the artery, we're going to see a thicker muscle wall. That's called the tunica media, kind of in the middle of the tube. Yep, see it up here? The tunica intima is the inside of the tube. And basically that's going to be endothelial cells. What kind of cells are those? What kind of cells are they? What kind of tissue?
It's connective tissue.
No, it's epithelial tissue. Okay, because remember epithelial tissue lines and covers, right? So endothelium is epithelial tissue, and you can see it best here in the capillaries. That's the tunica intima. Now, the artery has a subendothelial layer, and everybody knows that epithelial cells have a certain pattern. Cells attached to what? Basement membrane, and what was underneath? Connective tissue. Yes? Connecting me to somebody else. And that's what the subendothelial layer is. So both arteries and veins have that. Now wait a second, there's something else that we see in an artery. We see an extra layer. It's called the internal, and we also are going to see it outside, elastic membrane.
External elastic membrane?
We have two of them. In the artery, we see one inside that the vein doesn't have, and we see one outside that the vein doesn't have. What do you think they're for? Remember, I'm big pressure coming into my arteries from who? Who's pushing blood out? Yeah, we have to stretch and come back, stretch and come back. So when we talk about arteries, we're going to see extra layers, extra elastic lamina, both inside and outside, to help that vessel stretch. We don't see that in the vein, right? And then the tunica externa is basically connective tissue that's kind of tying everybody up, holding the tubes together. And that's the tunica externa. And those are collagen fibers, mostly connective tissue. The other thing we see in a vein that we don't see in an artery are these things.
Valves.
What did valves help us do in the heart? Prevent what? Prevent backflow. Because the pressure, and you're going to see that in a few moments, in the venous portion of this circle starts to go way, way down, we have to somehow prevent backflow. So in veins, we're going to also see valves. You don't see those in arteries because everybody's moving really, really fast. We don't need that. But in the venous system, we need valves. So those are some of the differences between arteries and veins. In the lab, you're going to go and look at them under the microscope.
Is this microscopic?
Yep, this is histology. One of my little tricks for my students in my labs, pay attention to the lumen. Do you see that little squiggly wiggly on the inside? When you look at arteries and veins under the microscope, size doesn't mean anything. Okay, because there's some large veins and there's some small veins and there's some large arteries and small arteries. But that little squiggly in the center is a dead giveaway. What do you think that squiggly is caused by? The elastic. So it's like me taking my elastic that was stretched out with blood in it, and now I have a piece of tissue. Do you see what I mean?
It's got some coiling.
Correct. So when you look at it under the microscope, look for the little squiggly lumen. That's dead giveaway for artery. The vein is going to be a little bit more smooth. The vein's also going to be of the same size. The vein is going to be thinner walled than the artery. But that's not always necessarily the case depending on what you're looking at under the microscope. Yeah, but see, it's just because of the way the tissue is cut. Yeah, so that it's tough to see that.
So how, I know you said the squiggly is what identifies the artery, but
Mm-hmm.
you said that they can be small or big.
Yeah,
So-
because when you look at the circulatory system, arteries and veins, it's basically like a tree. So the heart would be the trunk of the tree, and then we're going to branch all the way. So you can get a piece of tissue with a larger artery and a smaller vein just because of where the tissue was taken.
So how would you identify, I mean, I know you said this was the artery, but what can I use? I know it's a thinner wall for a vein, but.
Right, and it could be, you can't look at the size because it could be a larger vein versus a smaller artery.
So just identify the artery first.
Yeah,
Is that what you're saying?
and look for that squiggly portion on the inside, that inner lumen. So know the difference between arteries and veins. So this is a closed system, yes? We already discussed that when we talked about the heart. The heart is the pump, and then the blood vessels connect to it and push. Basically, their job is to push blood through the system and to make sure that that blood has oxygen and gets rid of carbon dioxide. It's going to help it get to places to get rid of waste products as well. So this is sort of the pathway of my closed system. In the capillary beds, those very thin endothelial places, you're going to see that blood actually moves through. Red blood cells have to move through single file. They're so thin. Exchange is going to happen here of nutrients, wastes from the tissues, gases, carbon dioxide, oxygen. But the other thing that's going to happen in those capillary beds is fluid, plasma from the blood is actually going to leak out there as well. Sometimes more than should be. Another system, the lymphatic system, One of the jobs of the lymphatic system is to help reabsorb back into the circulatory system some of those excess fluids that leave the capillary beds from the circulatory system. So when we discuss the lymphatic system, we'll also talk about this not closed system, but open system, which starts here in the capillary beds and then eventually works its way through a series of a whole bunch of different tissues before it dumps back that extra tissue fluid into the circulatory system. So we also see capillary beds in the lymphatic system. Again, what are they doing here for us with respect to circulation? Picking up excess fluid. Excess fluid. And bringing it where?
Back to heart?
Back to the circulatory system. So when we look at the vessels, the blood vessels, the lymphatic vessels look very similar to veins. And they will dump back into the circulatory system right around the superior, inferior vena cava region so that that fluid can make it back into the circulatory system and move through the body. The circulatory system couldn't do it on its own. And sometimes if the pressure is too high in the system, what do you get in your patients?
When it's what?
When their blood pressure is too high. What might that, what's edema? Where the fluid is having a hard time getting back into the, exactly. So you might get a buildup in the extremities.
That's why the people who take a lot of sodium, like salts and all of that stuff, they actually have a problem with reabsorption.
Correct.
Because there's a lot of sodium in.
And that has to do with blood osmolality, and we'll talk about that in chapter 27, and electrolyte balance. So this explains some of the different types of arteries and what their differences are with respect to the tube. So we have elastic arteries. Those are the first ones. Those are the closest to what? Closest to the heart. The aorta is a good example of a nice big elastic artery. We're getting blood that's being pushed from the left ventricle. Big, huge push, big, huge pressure. So what I'm going to see there in the elastic artery is something that I have to stretch a lot of. So look at the ratio of endothelium, which stays the same in the whole chart. That never changes. But we have more elastic tissue in an elastic artery. We also have a good deal of smooth muscle, and then we have that stuff that wraps around the outside. The second set of arteries, further on down the line, are the muscular arteries. Why do you think we call them muscular arteries? There's more muscle, exactly. Now, these are what we call the distributing arteries. So that muscle is going to help push things. Think of your tree. It's going to help push things up different branches to different places. Exactly. So we're going to come off the main branch, the trunk, and then get shuffled off to different places, like the kidneys or the heart or wherever it is my travels will take me as I go through that branch. So muscular arteries, more muscle in the walls, a little bit less elastic, and they're going to help distribute things through the body. As we get smaller and smaller and smaller, we start to become an arteriole in our branch. Arterioles, we're getting thinner and thinner walled. And again, getting to very specific places for exchange. The exchange part happens where? In the capillary beds. So the capillary beds are basically a very thin. It's so thin they don't even show it on the graph of a wrapping with an endothelial layer. 1 cell layer, 2 cell layers thick. Reason for that? I need to pass things in and out, right? It's got to happen fast. Do you think I have much exchange of nutrients and gases in my elastic arteries? No. How come? Because the wall's that thick. It would take me 17 years to pass through all the cells. So the capillary beds is the business end. This is where exchange of gases and wastes and all of that good stuff is going to happen. We're still connected. We're not going to unconnect. We're going to continue on my series of tubes. And we're going to start flowing into the venous portion after exchanging the capillary beds.
There's no elastic tissue at all.
Nope.
You know?
Nope. It's because I don't need any. Everybody's pushing from behind, right? So I don't need any elastic tissue anymore. So the venules are the smallest beginnings of the venous system. Again, endothelial cells, we're starting to get a little more muscle and a wrapping on the outside so everything doesn't fall out. And then a vein, which is mostly muscle and outer covering. We're bringing blood back to the heart for another push. And so we can go to what portion for gas exchange? Where do we need to go? We have to go to the heart for two reasons, remember? Pulmonary pump, right? You have to go to the lungs, get rid of the carbon dioxide we've picked up in the tissues, and pick up what? Oxygen that we dropped off in the tissues. And then we're going to need another what? We need another big push to do it all over again. So we have to come back to the heart and go to the systemic side and get a big push to go to the system.
So all the wastes, the capillary will pick up the capillary bed. We will rid of them through the emitters.
When we're talking about respiratory gases, but there's a whole bunch of other places, right?
Not respiratory gases, but just any wasted.
Right, but where will we get rid of that? In the capillary beds of the kidneys, in the capillary beds of the integumentary system. So we have to make trips. We might have to make several trips through the circulatory system before we actually make it to a place that's going to help me get rid of waste. Okay? It depends on where I end up on my ride. So think of the tree and its branches as a random thing. You know, your total blood volume moves throughout your body, but we might have to go several times through the body so that everybody can make it to the kidneys, so that everybody can make it through the liver. Do you see what I'm saying? Does that make sense? Okay, capillaries aren't just capillaries. Capillaries have different functions depending on where they are. So capillaries are of different types. Endothelial cells, they all have them. But there's 3 different types of capillaries depending on where I am and what I need to do. The first one's called a continuous capillary, and you can see it up at the top. Why do you think we call it a continuous capillary? Huh? Yeah, all the cells are nicely stacked, very, all the endothelials side by side like little soldiers around the whole entire tube. Very tight. Where would I find a continuous capillary? Places where I want exchange to happen, but I want to be very selective of where my exchange happens. Okay? Places like the brain, for example. When blood passes through your central nervous system up to your brain, I didn't want just anything to flow out of the circulatory system into my brain. And you talked about this last semester when you talked about the blood-brain barrier, right? Remember the ependymal cells? What do they do for a living? The choroid plexuses, what were they doing for us?
They actually, they're giving nutrition for the brain.
Well, how were they giving nutrition to the brain? They're making something. Cerebrospinal fluid. And that is basically filtering blood plasma. So we're going to find these types of capillaries in places where I want to make sure I am very selective of what I want to come on the other side. So cerebrospinal fluid is what we call an ultrafiltrate of blood plasma. One of the biggest problems for drug makers, people who are trying to produce a drug that they want to have an effect on the brain, is to overcome the blood-brain barrier. because those cells are going to be very selective on what they bring in and create or put into spinal fluid. Okay? So where I want to be picky about what I'm exchanging, we're going to find these type of capillaries.
So what kind of will be in the brain? Fenestrated capillaries?
No,
No?
continuous capillaries.
Will they will be in the brain?
Yes.
So they less permeable.
Well, they're more selectively permeable.
Okay. But it just says there, so it's less permeable.
Right. Much more selective about what's going to pass by. Okay? The other type, fenestrated capillaries. I'm going to give you an Italian lesson right now. How do you say window in Italian?
Well, I know in German it's Fenster.
It's fenster, fenster. In Italian, it's finestra. Do you see where we're going with this? The fenestrated capillaries have endothelial cells, but what's in the endothelial cells?
Windows.
Spaces or windows. Yes? So fenestra means window. We can have more and faster exchange when we have fenestrated capillaries. So where am I going to find fenestrated capillaries? In places when we discuss the kidneys, when we talk about nephrons, when we talk about an area called the glomerulus. The way the kidney works, kind of a pain. What happens is blood rushes into a whole bunch of capillaries, fenestrated capillaries, and as much as they possibly can, fluid gets sucked out of blood. Way more than you actually need to take out. And then what's going to happen? We're going to run through a series of tubes and bring stuff back that we shouldn't have taken out. What's left, we're going to pass as waste, and that's urine. So fenestrated capillaries, things can move much quicker because of the shape of the endothelial cells and those little fenestrations or windows. And last but not least, we have something that looks like Swiss cheese. Absolute mess. Big, huge holes. What's this for? Sinusoid, sinuses. Big, huge what? Bless you. Spaces. Sinusoidal capillaries are in places where big, huge things have to pass. Well, where might that be?
Bone marrow.
Yeah, and what are we talking about? You guys learned something for your last test. We talked about red blood cells and white blood cells and platelets, right? Where were they born? In the red bone marrow. Where do they end up? In the circulatory system, right? So hematopoietic stem cells, depending on what their stimulation is, have to mature and then squeeze their way through sinusoidal capillaries into the circulatory system. So when I have to pass big, huge things back and forth in the capillary beds, I'm going to see this type of capillary. Yes?
We'll bring them back for.
No, they're going to come from their maturation, like the red blood cells, for example, erythropoiesis. They're going to squeeze out into the circulation. Yes.
How about those that we have to rid of, like those?
Those will be in the, where do we get rid of those? Liver, spleen, so we'll see them there as well.
The same capillaries will bring them back for.
Correct.
break them down. Just
Huh?
a
Correct. We good? So know the different types of capillaries, continuous, fenestrated, and sinusoidal capillaries, and where I might find them. When we talk about the capillary beds themselves, think about the leaves on your tree. So the branches get thinner and thinner and thinner. The tree's kind of an end, which isn't a very great example. But the capillary beds is where we're going to have exchange. Now, in the capillary beds themselves, we can see, just like the tree, a whole bunch of offshoots that can happen in the capillary beds. Depending on what has to happen circulation-wise, when I'm running to the bookstore to get my delicious hermit cookies, I might not need everybody to make all their stops in the capillary beds, right? I might need you to move blood through a little bit quicker, yes? And I have little sphincter muscles that are going to control flow through the capillary beds. So if I'm running to the bookstore to get my delicious cookies, I might not need everybody to take a stop everywhere. I got to move my blood quick and get it to where I need to go. When I'm sitting down enjoying my delicious cookies, those sphincter muscles can open and we can go into the offshoots and make sure everybody gets what they need. So these sphincter muscles help to control blood flow, depending on what type of blood flow I need through the system.
But is it still moving for exchanging and
Correct.
everything?
And that's called what we call the true capillary beds. So the true capillary beds are where gas exchange takes place. And basically in the diagram, it's where it's the purplish area. So where we go from red, we start to change colors in the purplish area, and then we go to blue. The purplish area are where exchange takes place, the true capillary beds.
It's kind of like in the middle?
Yep,
The circle?
in the middle of the circle. See, again, where the purplish, you can see it better in your book, but you see that purplish region.
Sphincter muscles help to control blood flow.
Through the capillary beds. Yep. And again, the capillary beds, the meta-arterioles, the offshoots, this is where we're going to start to see exchange. The true capillary beds is where exchange takes place, again in those little purplish regions, and then we start to feed all the blood back for another push and to get rid of carbon dioxide. So we enter the venous system at this point.
But why do we need to go very quickly?
Again, because if I need blood supplied quicker, faster, moving through faster, you'll see those sphincter muscles close off. It depends on what's happening.
So if we address and we don't need a lot of maybe...
Or say, for example, you're enjoying your delicious cookies, right? And your muscles of your arms and legs, they're not really moving very fast. But the muscles in your mouth and in your stomach and in your digestive system want a little bit more oxygen to the tissues because they're working harder. There, we're going to open up those sphincter muscles and get the exchange happening in a bigger area. The other guys don't need so much, so we're going to close those little areas and not give them as much.
Oh, so it's not everywhere.
No, it depends on what's going.
Everywhere.
Exactly. It depends on what's going on, how much the tissues need. If the tissues need more oxygen, those sphincter muscles are going to open up to give them more. If they don't need as much, they're going to close off, and they'll get what they need. Yes?
Yeah, makes sense.
Makes sense? You got that confused look on your face? or you just breathing through your mouth? Okay. Okay. So the next thing the book talks about is the venous system. And again, we're talking about much lower pressure here in the venous system. Venules, small little veins, feed into larger veins. And remember, valves prevent backflow. Varicose veins are ones that have sort of been pushed on a little bit too much pressure in the system. We're kind of stretching them out, and they can be a real pain in the keister. Anybody have problems with them? Oh. And that's what happens. The veins, again, think of that elastic. They get a little bit too stretched out, and they become a little more leaky. They leak out fluids more readily than a normal vein becomes.
How about those capillaries that actually kind of like a breakdown and you have kind of like a,
That's what it, yes.
web
Yep.
with like,
That's a varicose vein. Yep.
is it the same thing?
Yep. And it can be,
Protruding.
not necessarily, it depends on the degree. Some of the higher ones can actually protrude and cause all sorts of pain. The little spidery ones don't tend to have as much problems for you. Yeah. Yeah, and why do you think pregnancy would cause you to increase the pressure? Because now you're carrying a child, you are supplying blood to that child, your blood volume actually increases, pressure in the system increases. So you increase your chance of developing varicose veins. Yeah, and there's procedures that can actually help to, yeah.
If you have a severe venous,
Varicose veins.
if you have just a little, they would not do it.
No.
Surgery.
No, no. You can do a little laser procedure. I think lasers can
It's a
do
lot
it.
of money. I looked
It's,
into
yeah,
it.
it's expensive.
I have them all over my leg. Like, for one leg, it's $3,000. Not that because I have both legs that have them.
So that would be $6,000 for you.
That's right.
Okay, so know those differences in the venous system, and they just kind of repeat. This chapter can be a little repetitive, yes? So they're kind of repeating information that we've already discussed.
Can you focusing, because I read it before, I kind of...
Anastomosis? Okay, so anastomosis, think of those capillary beds and all their little offshoots. You have the ability to make more offshoots in your circulatory system. So when you increase tissue, for example, when you get more adipose tissue, for example, we can actually create more offshoots of the circulatory system to make sure that everybody gets the nutrients that they need. Offshoots is like the tree. Think of the branches, exactly. So when they talk about collateral channels in anastomosis, they're talking about the fact that any given area can have many different ways to get food to them, many different offshoots, many different channels.
Do they have a capillary beds as well?
Yep, and we'll see that when we discuss the lungs, for example. There's many different offshoots of the circulatory system that will service a certain area in the lungs. They're called bronchopulmonary segments. Not only offshoots of the circulatory system, but offshoots of the respiratory system, because the respiratory system kind of does the same thing. So vascular anastomosis basically describes some of the different ways to service a certain area of tissue. There's many different channels or branches of a tree that will service a certain area of tissue. Does that make sense?
Yeah.
The little, So that's what an anastomosis is. It's basically different channels, exactly, different branches that service different or similar areas. That's what makes the circulatory system and respiratory system so efficient. Because I describe the hemoglobin molecule as an amusement ride, yes? So say you went to the amusement park and you wanted to get on the Ferris wheel. What would the man do so you can get on the Ferris wheel? He would stop the Ferris wheel, the people would get off, and you would get on. Well, it doesn't work that way. We're not going to stop the Ferris wheel for you in the circulatory system. We're going to keep it going very slow, but you've got to jump off and somebody's got to jump on. Yes? That would be fun, but sometimes if someone gets scared and doesn't want to jump off, they're going to stay on. Yes? So that's the way the hemoglobin molecule will pick up oxygen and drop off carbon dioxide and so forth in the system. So by having all these little offshoots or collateral branches, we can assure that we efficiently service all areas of tissue throughout the body. Because if one branch doesn't do it, somebody else will. Make sense?
But both of them will work at the same time?
No, not necessarily. It's just like the Ferris wheel. You might not be able to jump off, but maybe there's a Ferris wheel next door where somebody was able to jump off. So we'll make sure that everybody...
One system is working, another is off.
Not necessarily. They may both be efficient. You might both jump off at the same time. But the bottom line is you're going to get an efficient distribution of nutrients, waste, and gases because there's so many different branches for one given area. Yes? This diagram shows us the distribution of what? Blood volume through all of these tubes. Where is most of the blood volume in your tubes? It's in the veins. It's in the systemic veins and the venules, 60%. 5% of your blood volume at any given time is hanging out in the capillaries for exchange. And then the other, what is it, 12, 27, 36, 35% is hanging out where? In the arteries and the heart. It's getting its push. It's getting there. So most of it's trying to get back. The other's trying to get the push. And only 5% is really where exchange is taking place. They do a little, they give you a little closer look at cardiovascular disease and how plugging up these tubes can be a big issue. This is atherosclerosis, and this is a tube where normally we should see a nice wide open space where there's plenty of blood flowing through the whole tube. We see a plaque. These plaques are typically made of dropped off what? Fatty deposits, cholesterol. Atherosclerosis can be a big problem because it can block one of the ways to get there. And the biggest problem happens when I take all those little branches and I block before them. So if I block before all the branches, none of the guys after me are going to get any blood, right? And what's going to happen to all that tissue? It's going to die. So when I start blocking larger blood vessels, I have a big problem with the tissue that comes after it, and it can die. So myocardial infarction, stroke are just two examples of blocking some of this tree and not allowing blood to get to different areas. Tissue will start to die. So just a general understanding of what atherosclerosis is and how it can be detrimental to patients. Physiology of circulation is next. So we're talking about blood flow, we're talking about blood pressure, and we're talking about resistance. Resistance, that would be me rubbing my hand against the sides of the wall. Now, if the sides of the wall are nice and smooth and lovely, my hand goes quickly, yes? But what if this chalkboard was sandpaper or gravel? There would be more what there? More resistance. So resistance is also going to affect blood flow as well. So we will pick up on Thursday with the second part of this chapter.